You ever get that nagging ache in your knee that just kind of shows up? No big fall, no crazy sports injury, just this pain that you can't really explain. Well, it's incredibly common. And today, we're going to dive into the official clinical guidelines to figure out exactly what's going on. So if you're nodding along right now, this explainer is for you. We're focusing specifically on what doctors call non-traumatic knee complaints. That's the fancy term for the kind of pain that just creeps up without any obvious reason. And trust me, if this is you, you are far from alone. Get this, for every 1,000 people, about 34 of them will go see their doctor about knee pain this year. It's actually the most common issue right after back and neck pain. So yeah, it's a big deal. Okay, so doctors basically split knee pain into two big buckets. Over on the right, you've got your traumatic injuries, the stuff that happens from a specific event, like a fall or a tackle. But we're not talking about that today. We are zeroing in on this list on the left, the 6 most common culprits behind that mysterious knee pain that just seems to come out of nowhere. So here's our game plan. First, we'll look at the detective work your doctor does. Then we'll get to know the 6 most likely causes. After that, we'll jump into the really practical stuff, how to actually manage the pain, before we wrap it all up with the key takeaways you need to remember. Right, so you've booked that appointment. What's next? Let's walk through exactly how a doctor approaches your knee pain when there hasn't been one single clear injury. It really boils down to 2 key things. First, and most importantly, the doctor's going to listen to your story. They call this the anamnesis. And second, they're going to do a physical exam of your knee. It's that classic, powerful combination of just listening and looking. Your story is seriously the biggest clue they have. Your doctor's going to ask questions just like these to build a picture of the problem. Is the pain sharp or is it more of a dull ache? Does it scream at you going upstairs? Does it ache after you've been sitting for a while, like in a long movie? Every single answer helps narrow down the possibilities. Now, here is a super important point from the guidelines that might actually surprise you. You'd probably think the next step is an X-ray or an MRI, right? But for these kinds of conditions, that is usually not recommended. And the reason is pretty simple. What a scan shows often has very little to do with the actual pain a person feels. Your story and that physical exam, way more valuable than a picture in this case. All right, so based on all that detective work, your doctor is probably going to zero in on one of these 6 common conditions. Let's meet the usual suspects. Okay, the most common one by far is knee osteoarthritis. You can think of it as wear and tear on the joint's cartilage. The classic signs are pain that gets worse when you move around and that startup stiffness you feel first thing in the morning. This is really common in people over 45. But what if the pain is more around the kneecap itself? Well, that could be patellofemoral pain syndrome. The classic giveaway here is something called the theater sign, that ache you get from sitting with your knees bent for too long. Climbing stairs or even cycling can also really set it off. Then there's bursitis prepatellaris. This happens when a little fluid-filled sac right on top of your kneecap gets inflamed, and it creates this kind of squishy swelling. It's often called housemaid's knee because it's so common in people who have to kneel a lot for their work. Now we're getting into a couple of classic overuse injuries. If you feel a sharp pain on the outside of your knee, it could very well be iliotibial band syndrome. You've probably heard it called runner's knee, and no surprise, it's common in athletes who do a ton of repetitive bending, like runners and cyclists. And another really common overuse injury is jumper's knee. This time, the pain is at the front of the knee, right below the kneecap. And just like the name says, it's really common in sports with a lot of explosive jumping. Think basketball or volleyball. And our last one is a little different because it mainly hits active kids and teenagers who are right in the middle of a growth spurt. It's called Osgood-Schlatter disease. It causes inflammation right where the tendon from the kneecap attaches to the shin bone, and it often creates a painful bony lump you can feel just below the knee. Okay, so we've met the potential culprits. The big question is, what do you do about it? Let's start with the most common one, osteoarthritis, and what the evidence actually says. Now, when it comes to treatment, the guidelines are crystal clear about what works and what doesn't. What's recommended? The foundation of care is exercise, physical therapy, and if you're overweight, weight management. Simple painkillers are just there to help you stay active. And what's not supported by the evidence? Things you see advertised all the time, like glucosamine, certain injections, and even braces. And look, if you take away just one thing about managing osteoarthritis, let it be this.
The absolute core of the treatment isn't a pill or an injection. It's movement. Keeping active in a smart way is the single most powerful tool you have to manage your pain and get back to doing what you love.
So, what about those other 5 conditions we talked about, from runner's knee to jumper's knee? Well, while they're all different, the way you manage them is built on one simple shared idea.
It all comes down to balancing load versus capacity. Just think of it like a seesaw. Load is everything you're asking your knee to do. Running, jumping, kneeling, you name it. Capacity is what your knee is actually strong enough to handle right now. Pain is just a signal that the load is too heavy for the knee's current capacity. The whole goal is to get that seesaw back in balance.
So how do you actually do that? Well, the guidelines suggest a really straightforward approach. First, for about 1 to 2 months, you need to ease up on the specific activities that are causing the pain. But, and this is key, don't just stop moving. Switch to low-impact things like swimming or cycling to keep your fitness up. Then, as your knee starts to feel better, you can gradually and carefully start to bring your favorite activities back in. It's all about listening to your body and managing that load.
Phew, we have covered a lot of ground, from diagnosis all the way to treatment. So let's boil this all down to the most important things you need to remember from all of this. Here are the 4 big things to keep in your back pocket. Number 1, your story is what really matters, way more than a scan. Your diagnosis is clinical. 2, for osteoarthritis, movement is medicine, period. An active lifestyle is your best treatment. 3, for most other knee pain, it's all about that balancing act, matching what you do to what your knee can handle. And 4, be an informed patient. Know that things like glucosamine supplements just aren't recommended by the official guidelines.
So as we wrap up, I want to leave you with this question. Based on everything we've just talked about, what is one small, positive, active change you can make for your knees starting today? Whether it's a short walk, a few gentle stretches, or maybe planning a swim, every little bit really does count. Thanks for tuning in.